treatment of PPHN, and then this is going to be followed up by a case study as well. So over to you, Sam. Thank you.
Thanks, Lawrence. I'm going to talk mainly today, if it's all right, about the diagnosis of PPHN, but I will just start sharing the screen. Lawrence or anybody else, can you see that as a slide show?
It's on the first slide at the moment.
Yeah, great. Okay, so because we want to leave enough time for Matt's case presentation, I'm going to concentrate mainly on the diagnosis, and then we'll try and cover a bit of management of PPHN if there's time. There is a network guideline that I think Lawrence, as well as one of my colleagues, Katrina Firth and Porus Bastani, authored. So there's a link to that through the ODN website, and that covers a lot of the management. So that's a good resource as well if you've not already seen it. But just to start with a bit of physiology, apologies to anybody who's heard me talk about this before, but PPHN, so how does it happen? Well, when you're in the fetus, the pulmonary pressures are high normally, so that's a normal state of affairs, and they're high because the lungs are collapsed and they're not working as they would once you're born. So there's no air getting in and out of those. There's very little blood flowing through there as well. People often think of high pressure as a high flow state, but actually if the resistance is very high, all the blood vessels are collapsed down, that puts the pressure up, and that's what's going on in the lungs in the fetus. So the resistance is high, very little blood's flowing through, and the pressure in those lungs is high. Now when you're born and you hopefully have a big cry, your lungs open up and that draws air and oxygen in. But it also opens up those blood vessels and drops the resistance in all those little pulmonary vessels. And that allows flow through into the lungs, which then pick up oxygen and the lungs work as they're intended to do. But if that doesn't happen for any reason, if the lungs remain, if the vessels remain collapsed and in a high resistance, very little flow happens, and the pulmonary pressures remain very high because of the very high resistance. So what you get is a persistent fetal circulation in a baby once they're born, otherwise known as PPHN, so persistent pulmonary hypertension. So the normal state being in the fetus, it hasn't transitioned to the normal exuterine state of open lungs. So it's a failure of normal transition, and that's what PPHN is. And it's a problem because once your placenta's cut, your only way of getting oxygen is through the lungs. And even if you're getting air and oxygen into the lungs, if there's not enough blood flowing through them, then you're not going to return that to the heart and then to the rest of the body. So, as I said, we're going to concentrate mainly on the diagnosis, but we'll run through a few bits of the others. Etiology is very variable, and we'll have a look at that. Diagnosis, I'm going to talk about the role of echo in that because it can be a difficult diagnosis to make, to differentiate from congenital heart disease. Management is challenging, and it isn't important to remember it's not just looking after the lungs, it's looking after the whole baby, in particular the cardiovascular system. And I think, certainly from my experience, when you get a sick PPHN, it's one of the hardest babies to look after and really is proper intensive care because you need to be doing lots of things all at the same time and really paying a lot of attention to babies because they can deteriorate very quickly. So causes of PPHN, well, this is pulled straight from the network guideline, and there's lots of different causes here. I've just styled the ones I've tended to see more often and I think are more common. Idiopathics, sort of catch-all that we don't know, and I've seen lots of those, and the cause isn't always clear. Other causes is where you've got a normal set of lungs and a normal cardiovascular system, but something's happened to stop that transition to the from fetal life to the normal outside life, and that's when either you've had something like a meconium aspiration, which I think is the easiest thing to get in your head as causing PPHN. You've got a lung full of meconium, which not only blocks your airways but also causes pulmonary vasoconstriction. And the management of that is both looking after getting air and oxygen into the lungs, but also opening up those vessels, and they can be really challenging babies. The other things that can interrupt with that transition are things like localized chest infection and pneumonia, or a generalized sepsis where the baby's just not very well and doesn't manage that transition well, or a severe asphyxia. And occasionally you get babies who both need cooling and managing for their PPHN, and they can be a real challenge. Thankfully, not very often. Lots of other rarer stuff. The intrinsic lung abnormalities you don't see very often, but things like diaphragmatic hernias, where the gut's riding up into the chest and pressing on the lungs, not only cause a mechanical effect on those lungs, but also interfere with the development. So the airways don't develop normally, but the blood vessels don't either. When you're born, even if you manage to operate on the diaphragmatic hernia and bring that bowel down, it doesn't leave you with a normal lung, and they can be very challenging to manage indeed. Equally, if you've had a long period without much amniotic fluid, so you've got chronic oligohydramnios or very premature rupture of membranes, that can affect the development of the lung as well. So you've got small lungs that not only have insufficient airways to absorb the oxygen, but they've got tight, maldeveloped vessels that don't bring oxygen back from the lungs as well as a normal lung would. So diagnosis, well, it can be easy, but it isn't always. The X-rays on the right are hopefully fairly obvious in terms of what the cause might be. Anybody want to just shout out what the top right one is a probable cause? I can't see the chat, I'm afraid, so we'll. Anybody think they know what that one is, or the one below?
Is the one below a diaphragmatic hernia?
Very good, Dr. Wilcoxon. Top of the class.
Thank you.
Definitely not the heart, and that's it. No, not just the heart. Very good. Right. So that's a diaphragmatic hernia with a bowel wall in the left-hand side of the chest. Top one on the right, that's more consistent with a kind of meconium aspiration type picture. So babies like this normally present as a desaturated infant. The history, there might be a history, there might not always be. Things like meconium are fairly obvious, but it's important to try and dig into that history because you don't always get a good one. Mums with diabetes are at higher risk of babies having PPHN. Mums taking non-steroidals antenatally. There's a theoretical, or probably a realised risk that the duct might close prematurely, and the duct closing while the baby's still in the womb is felt to be a potential trigger factor for PPHN. And also, mums on antidepressants is also associated with increased risk of PPHN postnatally, although that's pretty unusual. It's always good to ask about antenatal scans. I've had to be quite specific over the years trying to ask about antenatal scans because on that said normal, but it's always good to check whether they've had a fetal echo because you feel a bit silly if it turns out later that they had a well-known cardiac problem. And then examination is always as important. The baby may well be breathless, but they're not always as breathless as the saturations might think they should be. X-ray is obviously going to help you exclude a pneumothorax or other abnormalities you can see on the right. And then congenital anomalies, not only on the X-ray, but babies, say, with trisomy 21 are much more likely to have PPHN than other babies. Oxygen, so I think the phrase of the nitrogen washout test, hyperoxia test has fallen out of fashion a bit, but giving oxygen is useful for these kids, partly because it's a really important treatment, but if you saturate normally with some oxygen, it makes congenital heart disease a bit less likely. The trouble is that it's not as reliable as perhaps the books tell you, in that there's some babies with very significant cardiac problems who appear to saturate quite normally and who swing the sats up and down, and it can trick you that giving oxygen is actually making the baby better. And likewise, babies with very severe PPHN with a primary lung problem don't always saturate well, no matter how much oxygen you give them. So it's not a reliable test, but I'd certainly be giving plenty of it. Pre-postductal sats, which we'll talk a bit more about in the next slide, I think are a useful thing to stick on a desaturated baby to give you both a guide in terms of what the diagnosis might be, but also in terms of monitoring for your ongoing management. So ductal shunting. So the reason pre and post ductal sats is useful is if the baby's got a duct after they're born, which most of them will, then it can be a useful way of picking up PPHN or a possible other condition without the need for echo. So in a duct, what you normally see, if you look at the top right there, if you put the echo probe on a baby, you often see this left pulmonary artery and the right pulmonary artery leading off, a nice blue flow, which means that's blood flowing from the heart off to the lungs. A baby with a duct in normal situation will have then the lungs open up, the pressures and the resistance in the lungs drop off, and the duct, if it's still open, the flow now goes opposite to the way it did in the fetal circulation, so it's coming from the aorta into the pulmonary arteries, and you get this big orange sort of flame flow. Normally, if in a preterm babies, which is where we see lots of ducts, we're sticking the echo probe on and we're looking for that duct showing lots of blood coming out of the aorta into the pulmonary arteries, and in those situations you get babies with wet lungs who are breathless because the lungs are all wet because they've got all this excess blood flowing around the lungs. But in PPHN that's different. What happens is, because the pressures in the lungs are still very high, they haven't adapted to the outside world, the resistance is still high, blood coming up that pulmonary artery finds it very difficult to go to the lungs, and then will preferentially come through this duct and down into the descending aorta. What that means is that desaturated blood coming from the right heart is then mixing with anything coming out of the aorta, and then dropping the sats further as you're getting lots of blue blood coming down into the lower body. So where you're measuring the sats on the feet will have lower sats than the sats that you're measuring on the arm, which is preductal. Now the preductal might not be normal either, because if there's not enough blood coming through the lungs, it's not oxygenating fully, or you might get a right to left shunt at the atrial level if there's not enough blood coming into that left atrium and the PFO is still open. So blood coming from the left heart is what's ever been around the lungs or through the atrial shunt. It's likely to be higher saturated than postductally, but still might not be normal. So as that diagram illustrates, you might have have lower saturations than preductally, but then the drop off is what's happening through the ducts, as all that pulmonary blood that should be going to the lungs is directed through that duct. And the use of a pre-postductal SATs measurement is, the bigger that gap gets, often what it's suggesting is, if the PPHN is the cause of all this, is that the pressures in the lung are higher than the pressures in the body, and the higher the pressures in the lung, the more blood gets pushed through and the bigger pre-post gap you get. And that's why it can be useful monitoring as well as help you with the diagnosis, because it will tell you whether you're winning in terms of dropping those pulmonary pressures or whether things are getting worse. Problem with pre and post is that you can also get a pre and post gap with congenital heart disease. So congenital heart disease can give you a cyanotic problem. So there's a list there of common, well, relatively frequently seen cyanotic problems. So transposition, right heart obstruction, so a tricuspid atresia or a severe Fallot's or a pulmonary atresia. CAPVD, where pink blood coming back from the lungs isn't getting to the heart, it's going back into the venous circulation, or a truncus with very narrow pulmonary arteries, all of which might cause mixing of the blood and shunting from right to left, so you've got cyanotic heart disease. The pre-post-ductal gap can also happen in congenital heart disease, particularly ones I've seen with left heart obstruction, where the diagram on the right shows you an interrupted aortic artery. I think is the easiest one to get in your head, in that the left heart's pumping blood up that aorta. You get nice normal sats, or supposedly nice normal sats coming up the aorta. But what happens then is it can't get any further. The duct's still open, hopefully at that point, and then you're getting desaturated blood coming into your descending aorta, which is what you're picking up in your postductal sats. And there you're going to get a big pre and post gap. So although most pre and post gaps are usually a sign of PPHN, particularly if they're consistent with the history, congenital heart disease is also on your differential then. So what can you do with echo then to try and differentiate between what might be a PPHN, which is probably the commonest thing we see, and what might be a congenital heart disease? So I'm just going to run through a few things and show a few pictures of what a heart might look like in a situation with PPHN. What you commonly do when you put your echo probe on is that you see a dilated right heart. And the reason you see a dilated right heart is that that heart is filling up because it's much harder for that blood to empty into the pulmonary artery. The resistance in the lungs is high, backing up there, and the right heart's filling and getting dilated. It does, of course, mean when you put the echo probe on, you have to be confident it's a dilated right heart and not a small left heart like a hyperplast, and that can be really difficult to differentiate between. And some people might find that quite tricky. I know I do often. And one of the things to look for is whether you've got a apical, whether the left ventricle is apex forming, whether it's actually fully developed or not, and that can be a hard judgment to make. The other thing you might see is a high tricuspid regurgitation velocity. So what happens is that right heart fills up because it's hard to pump blood to the lungs. What you're getting then is blood squirting back through the tricuspid valve during systole. The higher the velocity of that regurgitation, the higher the pressure in that right ventricle. During systole, that's equivalent to what the pressures, what the resistance is in the lungs. So if you've got high resistance in the lungs, you get high pressure in the right ventricle, and you get faster flow through the tricuspid jet, and you can measure that, and then you can estimate what the pressures roughly might be in the pulmonary circulation. Now, it's not the volume of tricuspid regurgitation you see. You often see tricuspid regurgitation small amounts in normal hearts, particularly postnatally. but the high velocity might suggest to you that you've got some sort of problem here with the right heart draining. It's easy to underestimate. It's often a difficult thing to measure, and you shouldn't be falsely reassured if you haven't got a very high value if your clinical picture suggests you've got PPHN, because you might be missing on the Doppler probe, and it might be very difficult to measure it accurately. So you have to just take it with a slight pinch of salt. The other thing you might see is a low pulmonary artery velocity. So in the same way you get high velocity going backwards, the right heart's finding it difficult to push blood around the lungs. And therefore the blood tends to be moving relatively slower, and the Doppler signal that you see normally is a nice U shape, and I'll show you a picture in a minute, but it's much more like a V shape because the blood kind of runs out of steam and stops going towards the lungs. One important thing to do when you're looking at that though is to check that pulmonary valve is opening, because if you've got pulmonary atresia, you'll see dilated right ventricle, high velocity TR jets, but you need to make sure that the pulmonary valve is opening to check that blood is flowing through, and it can be really difficult in a very low flow situation. Another useful thing to look for is flattening of the septum. So in a normal heart, there on the left side of the heart's under higher pressure and the septum tends to bow that way. In high pulmonary pressures, the septum will bow the other way. And what you see, again, I'll show you a picture in a minute, is flattening of that septum, and that can again be a sign of high pulmonary pressures. And then finally, the PDA, which you've talked about, when the resistance is high in the lungs, you get a persistence of what happens during the fetus, of it going right to left, or at least bidirectional, rather than the more normal left to right if the duct's open. So if you see all those things, they're all pretty suggestive of PPHN, providing, of course, you're happy to rule out congenital heart disease and any structural abnormalities, and that can be a challenge. Just to show you a quick few pictures, I've turned it the right way around because I think everybody, apart from me and a couple of other people, scan it this way now. So that, and it can be difficult to judge, but that right heart, certainly on the machine when I originally got the pictures, looks much more dilated than the left. That's TR velocity. So what you're doing there is you're putting the probe across the tricuspid valve, and you see, and that nice sort of envelope there suggests you've probably got a good reading. But what you're getting there is 4.5 meters per second of flow coming back through there, which gives you a pressure gradient across that valve of 83 millimeters of mercury, which is pretty high, which suggests whatever's going on in that right ventricle is very under a lot of pressure, probably much higher pressure than the systemic circulation in a newborn baby. So normally you'd see sort of 2 or less meters per second. In a newborn, you sometimes see 2 or 3, even when they're asymptomatic. But if you get up to 4.5, that to me is suggesting pretty significant right ventricular pressures. That's your PA Doppler flow that I was talking about before. Normally you get a nice U shape when you put your probe on the pulmonary artery, but that's much more of a V, and then you're meant to see this little notch here, and the sign of that, a bit non-specific, but it can be a sign of high pulmonary resistance in that pulmonary artery. Important to check there's blood flowing through, so I always like to get a picture there to show that blood's going across that pulmonary valve, so it's not an atresia, and you're trying to exclude a pulmonary atresia as a cause of those high right-sided pressures. Sepsal flattening, here's another quick loop. This is your left ventricle here, the lower one, the right ventricle's above. Normally the right ventricle's smaller and it wraps around the left heart, and that left heart is much more O-shaped. And in this situation it's more like a capital D, that septum's more flattened. The more flattened that gets, typically the higher the pulmonary, the right ventricular pressures, which is what you often see in high pulmonary pressures. Then the PDA. So on the left there's your Doppler signal, you've got blood going both directions. So typically you'd see it going left to right, you'd see a big orange flow up that way. What's happening is it's coming back right to left, and you can see that on the loop on the right hand side. You get an orange flash, then a blue flash, orange and blue, and that's a bidirectional duct. When we see that, when I see that, that tells me that the pressures between the lungs and the systemic circulation are roughly the same or similar. And now if you've got a decent blood pressure, that would suggest that your pulmonary pressures are higher than they normally would be. And you might see a pre-post ductal gap with that. Limitations of echo, well, it can be really tricky to do it in a really sick baby. They're often oscillated, the lungs may be hyperinflated, ultrasound doesn't get through air very well. So if you've got a poor echocardiographer trying to get pictures, give them some time and space to try and get some, because it can be really tricky. Some of the findings you see on congenital heart disease can mimic PPHN, and this is why you get babies calling up for embracing hospitals outside Leeds, saying we're not quite sure what we're dealing with here, even sometimes when they've had a scan, because it can be hard to differentiate between the two. So Epstein's gives you lots of tricuspid regurgitation. Might not be particularly high velocity, but it will give you, but then the valve is often in an abnormal position. Talks about things like pulmonary atresia, so you have to check that pulmonary valves opening, the tricuspid valves opening. CAPVD, I'll show you a picture in a minute about that. Hyperplastic left heart, there's a picture on the left there, so that right heart looks big, but it's probably because that left heart is underdeveloped in the apex there. The left ventricle isn't getting to the apex of the heart. Coarctation is always tricky to rule out and see, so you need a good views there. And cardiomyopathy, so we've had a couple of babies, well, at least one that I know of, with a dilated cardiomyopathy that were initially presented very much like a PPHN, but it was actually the X-ray, the really big heart on the X-ray, that gave us a clue. And the important thing there is to try and fit it in with everything else. The echo on its own is not the important bit, it's only to help you make the diagnosis alongside everything else. Next one, so CAPVD, so just to show you a picture there. So CAPVD is when your pulmonary veins aren't draining into your left atrium, they drain off in this one into the SVC, although it can be into the IVC. It can be really hard to spot on echo, because if in PPHN you get very little pulmonary venous drainage to that left atrium, and you have to be looking for that flow, and it can be really hard to see. But again, this is where your X-ray might come in handy. I've stolen this picture, I can't remember what it was, but I dug it out the other day, but it's meant to look like a snowman in a snowstorm. So you get the heart there, these are your dilated pulmonary veins where the head is, and you get quite plethoric lungs. Now, if you see that, and Hazel and Karen Swartz were involved in a case recently where the X-ray gave us the clue that this wasn't your typical PPHN, this may well be a TAPVD, and that was picked up on the X-ray. The baby didn't actually have an echo in the referring hospital, so that was a good clinical pickup. But it can be really difficult to differentiate between those two. Pulmonary veins, this is just what we're talking about with CAPVD. This is the view you're trying to get. So what we can see here is that big black hole in the middle is your left atrium, and we're looking right down on top of the heart. So the probe is up in the suprasternal notch, looking right down the back. And what we're looking for is these things coming in from the side. 2 orange flashes here, 2 blue flashes there, of pulmonary veins coming into that left atrium. But that's what you're hoping to see, but you can't always see it very easily. But that's what the scanner, this person doing the scan, is looking for when they're trying to exclude anomalous pulmonary veins. PPHN management, I've got a couple of minutes, so I'll just fly through this. The key bit here is what you're trying to do is break the cycle. The thing is in PPHN is that oxygen is a really good vasodilator. So the more oxygen you can get in, hopefully the more the vessels will open up. If they open up, they can carry more oxygen, and it becomes a virtuous circle. Problem is, if you get vasoconstriction, is that deprives the body of oxygen. You get more and more hypoxia, it causes more and more vasoconstriction, and babies can deteriorate. And because it's that vicious cycle, they can deteriorate extremely quickly, and it can be hard to get them back. So the management of these babies is really multi-system. In just respiratory, and this is where the guideline covers of this, so apologies for flicking through this very quickly, but these are the main areas which I'll just cover quick. So the basics, these babies, if you've got a desaturated baby, try and keep the light down and the noise down and handle them as little as possible. That picture's a baby who's probably not going to get much relaxation. Them getting stressed tends to make things a lot worse. You want to avoid sort of the basic stuff, so you want to avoid acidosis, anemia, check the HB is okay, treat infection, make sure the electrolytes are all right, check the sugar, keep them warm unless you're wanting to cool them. Breathing, so that's a very old picture of Sensormedics that some of you may look back fondly on, but we need to give lots of oxygen. You want to keep the SATs up, not probably 100%, but certainly good preductal SATs, 95, 98, and arterial PaO2s of 8 to 10, so enough oxygen go around the system. You don't want to wean them quickly like you would a preterm baby. You want to keep those SATs high. Intubation, there's difference of opinion on this. We're certainly more comfortable in Bradford leaving babies on oxygen if they're clearing the CO2 well and they're not working too hard. We tend to avoid CPAP here. We would use vapotherm if we felt it was indicated, but if baby is beginning to struggle, they need intubating. The problem I think with these is that sometimes you don't manage the cardiovascular system as well at the same time, and they decompensate when you intubate them. So it's really important to be looking after the cardiac filling and blood pressure Why are you thinking about this? Surfactant if there's meconium, but we wouldn't normally use it for any other reason other than prematurity. You're aiming for normal pHs and CO2s, and you give plenty of PEEP, and you might need an oscillator to keep those lung volumes up. Lines in, get the pre and post ductal sats on. It's really important. You don't want to be trying to put umbilical lines in if the baby's getting really sick, so we tend to do it early rather than later. Cardiovascularly, that's a bit of Goldilocks. You want a good blood pressure, but you don't want to thrash the heart too hard. So we tend to aim for a blood pressure around about 50, slightly higher than normal. What you're trying to do is reduce that pre-post ductal gap. You're trying to push that blood in a slight way back through the ducts so it goes around the lungs. What you don't want to do is be overloading the heart, either with too much volume or too many inotropes. So I've certainly had bad experiences with this before. You want to be supporting the heart so it pumps well, pushes blood around the lungs so it's well filled and is working well, but you don't want to be overdoing it and making the heart struggle and increasing its metabolic demand, because that's probably as dangerous as being hypoxic. There's a whole load of inotropes there that we could talk about all day, but there's not great any evidence for any of them, and the guideline goes into a bit more detail, but it's really up to what you're comfortable with and what you use locally. Echo monitoring can be useful. So there's two things I look for when we're managing a baby. So once you've made the diagnosis, you're happy it's PPHN. One thing you might be looking for, if there's not much blood coming back from the lungs, your left heart doesn't flow very well. And in severe cases, that means that you're not pushing much cardiac output into the systemic circulation. So if you see things like a flow reversal in the aorta, you're happy there's no structural problems, but that might suggest there's very little blood coming out that left side of the heart. So that it could be very poorly filled, so it might need some more volume, or it can be very dilated and the heart's not working well. And in those situations, you might want to add volume if you think it's underfilled, or you might want to add in further inotropes to reduce the afterload of the heart if it's very dilated, because what you don't want to be doing is too much vasoconstriction and making that heart work really hard. So milrinone's increasingly common inotrope that's used to try and reduce the afterload of the heart to make the left heart work better, and that might actually improve your oxygenation as it generally helps the circulation. With the right side, the right heart isn't really designed to be working under lots of high pressure, and if that's getting more and more dilated, then there are times when you might consider trying to open up that duct further with prostate. Not because you think it's a congenital heart problem, but actually what you're trying to do is help the right heart work by giving somewhere to pump blood out. So that feels a bit counterintuitive initially, because the pre-post gap you're wanting to reduce, and you're often hoping the duct will close to force blood around the lungs. But if that's normally what I would hope to do. But if you do an echo when you're monitoring these babies and the right heart is really getting more and more dilated and the function is looking more and more off, then you're worried then that you're going to get right heart failure, and then you're in trouble. So what a lot of people are suggesting might be the answer in that case is actually try and open up the duct further and at least give the right heart somewhere to drain the blood off to, and therefore try and help its function a bit. But these are pretty severe cases and they can be very difficult to manage. Nitric's an important part. Not available in outside big sensors, but Embrace carry it, and it can be very useful indeed. Reduces the need for ECMO, so it's definitely worth trying. Preterms, it does sometimes work, although the evidence isn't there, but it's for specific babies only. Calculate your oxygenation index because it's a very useful way of doing it. I'm just flying through now. An ECMO can get you out of trouble in very severe situations, but it's best to call them early, because I'm not sure if Leicester is still doing much in terms of mobile ECMO, and Leeds I know do a bit of ECMO, but the availability of it can be very restrictive. So if you're worried that this baby might need ECMO, I would always advise calling Embrace and talking to the ECMO coordinator as early as possible. They also can give you useful advice on management. So thank you for that. When it's bad, PPHN can be really, really bad. So it needs lots of work and it needs lots of attention to detail. Lots of oxygen, don't wean it too much, keep the blood pressure up but don't overdo it. Always think that you might be wrong and ask a friend, and ring Embrace and ECMO if you're worried. And that's it. Sorry, I've run a couple of minutes over.
No, that's brilliant, Sam. Thanks very much. That was a tour de force of PPHN.